Hello, and welcome back to our clinical case series. I hope you're enjoying everything that you're learning so far. Everything from bone grafting, soft tissue grafting, sinus augmentation, implant placement, and laser regeneration. Do you find periodontal defects in the anterior aesthetic zone challenging to manage and challenging to get aesthetic results? Traditional GTR type procedures with bone graft and membrane often lead to papilla shrinkage and interproximal defects with the papilla shrinking, with an unideal aesthetic outcome. What if I told you there was another treatment modality that would lead to better aesthetics results, minimal discomfort to the patient, and better long-term bone predictability in terms of bone growth and bone regeneration? Well, there is. Come join me with this case as I walk you through the treatment that we chose to manage this periodontal defect in the anterior aesthetic zone. Let's highlight this periodontal defect on this radiograph dated 9/24. Look at the circumferential type defect extending from the distal aspect of tooth number 9, wrapping around to the palatal aspect with localized periodontal defects, roughly in the ballpark of 8 to 9 millimeters. And look at the aesthetic results, or look at the bone regeneration at 18 months. Notice the osseous fill on the distal aspect of tooth number 18. Incredible results. We know with the laser assisted regeneration protocol, we know that 80% of osseous fill occurs within the first year post treatment. We know that we'll get an additional 15% of bone fill in year two, and an additional about 5% of bone fill in year three. So, again, with one laser treatment, I will continue to get improved density in bone fill for up to 3 years. This was a case referred to me by a good friend and colleague, Dr. Nathan Khoe. If you're looking for a good general dentist in Durate, California, in the San Gabriel Valley, give his office a call. His office number is 626 305 1320. You're in great hands if you choose Dr. Khoe for your restorative general dentistry needs. A few learning objectives I want to walk through for tonight before we jump into this case in more detail. I want you to define indications, case selection, and identify two-wall, three-wall bony defects that are going to be most predictable for osseous regeneration. I want you to be able to summarize the Lanapp protocol in the anterior aesthetic zone, and I want you to be able to recognize possible complications and limitations and the evidence-based strategies for prevention and early detection and management of these cases. So here we are, initial presentation in September of 2024. The patient presents to my office with a localized periodontal defect on the distal aspect of tooth number 8, extending distally and extending palatally in around the tooth. Notice the root canal has been done and the patient is in provisional restorations. Currently, the periodontal prognosis on this tooth is guarded. I don't know if I can control for disease progression or not. I won't know unless I treat this tooth. But we don't want to move forward with final restorations until we have good periodontal stability on tooth number 8. So let's look at our periodontal bone sounding probe depths. Here we are on the distal aspect. We're getting about a 10 or an 11 from the facial. But let's look at that localized inflammation on the palatal aspect. That area probes approximately 8 to 9 millimeters, and that defect extends along the entire palatal aspect of tooth number 8. So how are we going to treat this tooth? We're going to treat this tooth with the Lanapp protocol isolated to a site-specific area. I want to walk you through the protocol and what that looks like quickly so you get a better understanding of how this laser treatment works in my office and works in my hands. First, we're going to do our bone sounding probe depths under local anesthetic. We do this because the bone sounding probe depths allow us to determine how much energy is needed for that site-specific area. Step B is going to be our ablation or selective removal of the diseased tissue and removal of the pathogenic bacteria isolated in that periodontal defect. In step C, we're going to use our piezo ultrasonics to remove any subgingival calculus and subgingival plaque. In step D, we're going to do our blunt dissection and bone biomodification. We're going to wake up the bone. We're going to wake up the stem cells. We're going to get those stem cells released in the form of a laser-generated blood clot that happens in step E. Once we do our laser-generated blood clot, this acts as our protective barrier. This acts as our membrane around that periodontal defect. So there's no more bone and there's no more collagen membranes when it comes to bone regeneration using this protocol. What will happen is that blood clot in the hemostasis mode will allow for those live viable stem cells to regenerate and turn into bone over time. In step G, we're going to do our occlusal adjustment, making sure all of those traumatic forces are removed because bone regeneration won't happen on a tooth that has mobility. So if we can control for the etiology of the periodontal pathogens and for the traumatic occlusion, we will get bone regeneration in the anterior aesthetic zone with minimal tissue shrinkage. Let's look at this 18-month follow-up. Look at the tissue quality. Now, the patient did not want to go through orthodontics, and she wanted that space, that diastema closed with restorations. All of this was talked about beforehand. But let's look at the periodontal stability of this tooth. You can see here I am probing with firm pressure. You can see the blanching of that distal papilla. Incredible. Remember how that area probed almost 10 millimeters? In 18 months, it probes 2. We can't get any better than that with minimal tissue shrinkage. No matter what type of flap reflection you do, there will be some type of tissue shrinkage and loss of papilla interproximally. This will not happen with the Periolase MVP7 laser. Look at the lingual aspect or the palatal aspect. Again, the tissue blanches. I can tell you I'm probing firmly. 2s and 3s. So we've taken this tooth from 10s on the distal aspect from the facial and 8s and 9s on the palatal aspect down to 2s and 3s circumferentially around this tooth. We have periodontal stability. So this tooth went from a guarded prognosis to a good prognosis. And remember, prognosis can change over time, and prognosis can be individual teeth or it can be the whole mouth. In this case, when I'm talking about prognosis, I'm talking about the individual tooth prognosis on tooth number 8. We allowed this tooth to heal for 6 months prior to making final restorations. At 6 months, I had reduction in probe depths, but again, when we took our radiographs, we didn't see much in terms of radiographic changes at 6 months. At 12 months, we started to see some, and at 18 months, we saw a big difference in terms of osseous regeneration from the preoperative radiograph to the 18-month postoperative radiograph following laser assisted regeneration. Again, I just want to highlight that radiograph in terms of the osseous fill with only a laser generated blood clot. So again, when it comes to good bony regeneration, we have to have 2-wall or 3-wall defects, meaning the amount of walls that are present. I need that defect isolated, and the more bone around that defect, the deeper the defect, the more predictable that regeneration will be. I hope you can summarize the LANAP protocol for me in a step-by-step fashion. And again, understand how that protocol works. Jump over into our other modules to learn about the laser physics. I don't want to talk about laser physics and why the laser works so well, and I don't want to put myself on repeat. That's in our modern periodontal concepts. If you want to learn more and see how things work step by step, jump over into our step-by-step surgical mastery course. I hope you enjoyed tonight's lecture, and I look forward to seeing you again. Thank you so much.